Good afternoon. My name is Horacio Asbun. I'm a surgeon here at Miami Cancer Institute. I'm the chief of Hepatobiliary and Pancreas surgery. I want to welcome all of you. We thought that during these crazy times, it would be good to be able to have this webinar that is more than anything to exchange knowledge, for us to be able to answer your questions. And I have a superb group of speakers that will be telling you what we're doing and how the treatment of cancer is being affected, or actually how we're overcoming what we have been forced to undertake by this crisis. I have to say that Miami Cancer Institute has done a tremendous job to ensure the safety of the patients as well as the safety of the staff. Because if we are not safe, you are not safe. Then as an introduction, I'm gonna say that every single patient that comes to the building, it is screened, and there is a setup that I'm not gonna bore you with, but depending if there are any questions that there's any doubt, then there's a secondary screening. And depending on that, we decide to test or not test the patients. And we can then secure that at least every single patient has been studied verbally first for safety. Then in terms of the people that works here, because we also could be carriers, we are also held at a very stringent standard. And the doors of Miami Cancer Institute have been actually controlled and closed except for one. There is one pathway to get into the building, and each of us is screened every day, even if we have to answer every single question. And for example, one day I was driving and my windows were open and it was hot. I arrived, my temperature was a little elevated. Then I didn't make the initial screening. I had to go to secondary screening. Then this is how serious we take this crisis, and rightly so, because our job is to take care of you, and our job is to take care of ourselves to be able to continue caring for our patients. Now, I'm going to be introducing our panelists. We have, as I said, a superb group of panelists, and each of us is going to talk a little bit about what are the changes that have been made in our specialties. And then we're going to have what I consider plenty of time to answer your questions. Some housekeeping issues. If you're not familiarized with the Zoom platform, if you move your arrow down, there's going to be an area that it says chat. Then you can ask any questions on the chat, and we're going to do the best we can for the moderators to pass the questions and be able to address it. You could do a general question to anybody, or you can ask directly to any of us as the lectures are being made. And finally, I just want to encourage you, this is your webinar. Then even though we're all in a camera and we look like important, we're not that important. What makes us important is to be here to be able to answer any questions. That's our job, and hopefully this platform is going to allow us to do that. Then the first speaker is going to talk about managing your cancer during the COVID-19 crisis. Is Dr. Siddhartha Venkatappa, who is our medical oncologist, and he will speak about the medical oncology point of view during this crisis. Dr. Venkatappa?
Right. Thank you, Horacio. Good afternoon, everyone. Glad to be here. I'm going to do this as a question and answer session. I've tried to imagine the questions that you may have, and I'm going to try and answer them. I have been given about 10 minutes, and I think there are going to be many more questions, so I look forward to answering them during the question and answer phase of this webinar after everybody finishes talking. First of all, as Dr. Asbun said, I would like to reiterate that I am so proud to be part of MCI. The leadership here and everybody has done such a wonderful job of protecting us and protecting the patients, that it is something unique. I've been speaking to my colleagues who are oncologists in other parts of the country, and they're surprised at the stringent measures that we've taken to ensure everybody's safety. So I just wanted to start off with that, because I think it's important to know that a lot is being done. So the first question is this COVID-19 virus really more prevalent in cancer patients or not? There's been just one study, and this is from China, from Wuhan itself, which was the epicenter where all of this started, which showed that the rate of COVID-19 in cancer patients was twice the rate of COVID-19 in the general population. Now, this is all initial data. This is data on about 1,500 patients. As you know, over 1 million people all over the world have been affected. So this is a small group, but it gives us an indication, an early indication that yes, cancer patients are likely to have COVID-19 more than the general population. Okay, that's number one. Second, if I have cancer or I had cancer, will I get a more severe version of COVID-19? Now, there have been a few studies done, and there was a systematic review done that showed that patients with a history of cancer who developed COVID-19 were more than twice at risk of getting into the ICU than somebody who'd never had cancer. So the answer is yes. With a history of cancer, your risk of getting a more severe version of COVID-19 illness does exist. So that's important to know. The third question, is the mortality of patients with cancer and COVID-19 higher than those who never had cancer? The answer to that, unfortunately, is also yes. With cancer, the overall rate of morbidity was 3.8%, mortality was 3.8%, and it was 1.4% with no comorbid conditions. But I would also like to mention that the same study, which came out from a joint WHO and China Joint Mission on Coronavirus Disease publication, and this was published on February 28th of this year, showed that while the rate of mortality in patients with cancer and COVID was 3.8%, if you had cardiovascular disease, your rate of mortality with COVID was 13%. So it shows you that there are diseases other than cancer which have a higher risk of morbidity and mortality if you get the COVID-19. I just thought this was an interesting piece of information and that I should share it with you. So next question. So what are the general recommendations for patients with cancer to prevent COVID-19? The answer to that is very simple. Follow the CDC recommendations. Those with cancer, those who take care of patients with cancer, those who are family members and caregivers of cancer patients need to be extra cautious and follow the CDC guidelines much more thoroughly than the average person. Simple things: wash your hands, wear a mask, avoid going out. The things that we have been reading in the press and seeing on TV, follow that. It works. It really works. Okay. Next question: cancer type specific guidance. How should care for patients with cancer be affected? Now, we have not found any evidence so far, and when I say we, I mean the scientific committee all over the world, that patients with one particular kind of cancer have a higher risk for COVID or will do worse. So all the data that I'm going to talk about from now on for the next minute or so is generalized data for patients with any kind of cancer. Okay, one would assume that those with lung cancer or those with pre-existing lung disease would do worse. Yes, that's right. But there are no specific guidelines that if you have breast cancer, you should do this. If you have lung cancer, you should do something else. Okay, multiple societies have come up with different recommendations, and the general consensus is, to put it in one line, continue treating, but limit the treatment, taking into consideration that you don't want the patient to end up in the hospital. Take into consideration that there's a shortage of blood and blood products. And if you can follow these two, you need to modify your treatment, and that should take care of the care of the patients. Now, next question. Can surgery be canceled or delayed? That's a detailed question. I'm going to let Dr. Asbun answer that. Another question is, should radiation be delayed? I'm going to let Dr. Chuong answer that. I'm going to limit myself to chemotherapy and other medical oncology perspectives. Okay? The next question, should chemotherapy be canceled or postponed? There has been no evidence found that chemotherapy should be cancer, for sure. We believe that cancer is a very serious illness, and we worry and we know that delaying treatment or under-treating a patient can allow the cancer to become more resistant. So the consensus from the American Society of Clinical Oncology and multiple cancer societies all over the world is that we should continue cancer treatment. But there are some caveats to that. For those with curative disease, yes, absolutely continue treatment. For those with curative disease, but where there are alternatives, say there's a choice between an IV chemotherapy and an oral chemotherapy, then we would say that for the time being of this COVID pandemic, we would choose an oral chemotherapy drug as opposed to an IV chemotherapy drug. Now, there are certain regimens which are much more toxic than certain other regimens. And I'll give you the example. For pancreatic cancer, there's a regimen called 4-FOXIRI, which has a very high incidence of neutropenia and decreased immunity and reduced cells and increased risk for transfusion. So the consensus from the American Society of Clinical Oncology is to try and avoid that particular regimen and switch to other regimens which may provide similar benefit. The same with breast cancer. For those with estrogen receptor positive disease, the consensus is that start on a hormone blocking therapy for the first few months, do something slightly different, and then switch to regular chemotherapy when the pandemic is over. Unfortunately, none of us know exactly when the pandemic is going to be over, so we are learning along with you. And what I find really beautiful in this period is there has been so much of sharing of knowledge. Nobody is keeping information to themselves, whether it's in the US or all over the world. There's been a lot of knowledge that's been shared, and each one of us learn, and we're able to treat you much better with that shared knowledge. And that shows you that, you know, irrespective of the borders that we have created for ourselves, the entire world is one human race. And in a pandemic like this, we have to treat each other as equal and everybody as important. The next question, should other treatments be delayed or avoided? By other treatments, I'll give you an example. A lot of patients with bone metastases get a drug called Zometa or Xgeva, and these drugs are to strengthen the bones and reduce the risk of fractures. Normally, we give that once a month, but for the duration of this pandemic, we have switched that to every 3 months because we feel that that will be adequate for the time being for this particular indication. Now, why are we doing this? Why are we reducing treatments? The main reason is we want to reduce footfall into this cancer center and to any cancer center. Anytime you come into contact with lots of people, especially in a hospital environment, there is an increased risk for catching the virus, despite the excellent work done at MCI, and I'm sure at other places too. And so our goal is to have you on treatments that reduce the need for you to come here to as less as possible. And that's why we've also taken the step of reducing or not allowing any visitors to come with you into the building for your own safety. And we've also stopped allowing a lot of ancillary personnel to be in the building, like students, drug reps, and I can also tell you that almost 600 employees of MCI are working from home just to reduce the number of people that you are exposed to when you come to MCI. The next question, should all patients be tested for COVID-19? The answer is yes. However, as you know, and you've read and you've seen on TV, there's been a shortage of tests. At MCI, we are very lucky that we were able to develop a test in-house, and we were one of the 20 centers in the United States that were given expedited FDA approval to run the tests. And so this has allowed us to increase the number of tests that we can run. So our goal is to get everybody who gets chemotherapy or immunosuppressive therapy or radiation or surgery to be tested before they go in for their procedure. We are almost there. We're there in some of those situations, not yet there in all the situations. Next question, should cancer therapy be delayed for patients with COVID-19 infections, and for how long? The answer is yes, it should be delayed. If you had an active COVID-19 infection, then your cancer treatment should be delayed for at least 2 weeks after you test negative after your COVID infection. This is the recommendation from the American Society of Clinical Oncology, and I believe this is a very prudent recommendation because those with who had the COVID-19 infection would have had a significant loss of quality of life performance, and they need some time to recoup before we challenge their already immunocompromised systems with more chemotherapy. The next question is, should immune checkpoint inhibitor treatment be delayed? As you know, immune checkpoint inhibitors are what we call immunotherapy. This is the treatment that has been the latest and the greatest in cancer care over the last 3 to 4 years. And these treatments are not traditional chemotherapy. They actually rev up the immune system and tell the immune system to go kill the cancer cells. Because this is different from chemotherapy, the recommendation from the National Society is to continue this treatment, but to reduce the frequency of treatment whenever possible. What about stem cell transplants and allogeneic transplants? Now that's a very complicated scenario, but the general consensus is to delay those treatments wherever it is safe and feasible. What about prophylactic antiviral therapy? Should everybody be on an antiviral like Tamiflu, especially those with active cancer getting treatment? The answer is no. And the reason for that is that Tamiflu does not work for this particular kind of virus, and there is no other treatment that has been shown to be useful as a prophylaxis. There's been a lot of talk about hydroxychloroquine. I'm going to defer to my dear friend and colleague, Dr. Gaviria, to discuss that in more detail, but the answer once again is no. Is there any impact of concomitant medications on COVID-19 outcomes? I'm going to let Timothy Gauthier talk more about this. There is some data, there's conflicting data, but he's our pharmacy expert, he's on the panel, and I let him answer this question. What about neutropenic fever and neutropenia? How should care be different? Neutropenic fever and neutropenia are common problems with this, with cancer care. We are trying to reduce the toxicity of therapies by reducing the number of drugs, by increasing the delaying the time between treatments. And we're also using growth factor stimulating agents at a lower level and trying to be more liberal with the use of antibiotics during this time to prevent neutropenic fever itself. What about cancer-related anemia? That's another very common problem. We have been more liberal with the use of growth factor support, once again, for red blood cell growth factor agents. We're trying to limit the number of transfusions because there's a shortage of blood products. What about the care of the portacat? Normally, we like to get it flushed every 4 weeks. We're pushing it to every 8 to 12 weeks whenever we can. What about cancer screening? That's the last question I'm going to answer before giving it back to Dr. Asbun. The consensus is to hold off on screening for the next few months. We feel that it would be safe in the most part, so long as patients are asymptomatic. We understand that it has some risks, but we believe that the less exposure you have to a medical facility, the better it is overall. And so the consensus from the American Society of Clinical Oncology is to hold off on regular screening for otherwise healthy individuals for the duration of this pandemic. With this, I'm going to stop. Like I said, there are many more questions that I'm sure you all have. I look forward to answering them later on. Thank you, Horacio. Horacio, you're on mute.
Thank you very much, Dr. Venkatappa. Our next speaker is Dr. Michael Chuong. He is the Director of Proton Radiation Therapy and MRI-guided therapy here at MCI. It's a great colleague, and he will be talking about the COVID crisis from the radiation oncology standpoint.
Thanks, Dr. Asbun. So it's a pleasure to be here. Thank you for your time, everyone who tuned in to hear about what we've been thinking about and how we've been approaching this pandemic. And I think a common theme you're going to hear throughout the webinar is patient safety is the utmost importance to us at MCI. And there's the challenge of balancing clearly safety with providing high quality cancer care. And that certainly includes the radiotherapy realm, in which up to 2/3 of patients with cancer have an indication to receive radiation therapy, and therefore it is a very commonly used treatment modality here at the Cancer Center. The other challenge is that radiation therapy most commonly is delivered once a day for multiple days at a time and over several weeks. And you already heard Dr. Venkatappa mention the emphasis on decreasing footfall within the Cancer Center to decrease exposure risk to patients. So how have we thought about that? And so I think an important point for everyone to understand is that the reaction from the Cancer Center leadership and from the clinical care staff has been a proactive one as opposed to a reactionary approach. And in fact, well before any positive patients were seen in the South Florida area, our department and leadership throughout the Cancer Center had a detailed plan about how we would approach every different scenario that is possible, from mitigating risk to patients who were negative, how do we approach treatment and care for patients who test positive, et cetera. And so, again, safety is of the utmost importance. Within the radiotherapy arena, I mentioned that many patients come for multiple days or weeks at a time. And so strategies that we've used to decrease the risk for potential infection in many ways were adopted from other centers who had come before us. For example, those from University of Washington in Seattle and others throughout the globe who, from a radiotherapy standpoint, had already needed to look at modifying their approach. And one of these is what's called the RADS framework, R-A-D-S. And I won't go into this in detail, but just quickly, the R is remote, so remote teleconferencing. So many patients who are probably dialed in here now have experienced a consult or a follow-up visit by Zoom or by FaceTime or whatnot in order to minimize your exposure to the environment here. The A is avoid. So are there scenarios in which radiation perhaps can be avoided in favor of a different and effective treatment that would require the patient to come fewer times to the hospital? The D in RADS is defer radiation. So sometimes radiation is clearly a necessary treatment and a critical one for perhaps providing cure for the cancer, but perhaps that's one that could be delayed until the crisis had passed. So for example, for patients with prostate cancer who are on hormone therapy, perhaps some patients who are on hormone therapy could have that extended some and then begin the radiation therapy a few weeks or months later without really a detriment to their care. And clearly, patients who need radiation sooner, we certainly would discuss that with the patients. And in that context, the S in RAD stands for shortened radiation therapy. So can we decrease the number of times that patients need to come for treatment? And in fact, we have increased the emphasis for use of short course radiation. So as opposed to coming for multiple weeks at a time, there are some regimens that can be appropriately used where patients may come for only 1 week at a time. And in extreme scenarios for very select patients, maybe just one time instead of 1 week or multiple weeks. And so all of these strategies have been considered and have been put into actual practice here at the Cancer Center from a radiotherapy standpoint. The last point I'll make, and I'll give it back to Dr. Asbun, is that because there are many patients who come in and out of the radiotherapy department and are treated on the same machine, I want to ensure all of the viewers out there that there are rigorous cleaning processes that are in place, not only for the patients who are treated or the rooms that are treating patients who test negative, but of the utmost importance is how do we address that for patients where we know that we're treating positive patients. So those processes are well in place, and again, the utmost importance is for the safety of our patients. So with that, I'll give it back to Dr. Asbun.
Thank you very much, Dr. Chuong, for the informative lecture. I'm going to talk next about surgery. Basically, there's not much to say other than what it has been repeated. The patient safety, and for us to continue the treatment of your disease, is what is on our minds at all times. And yes, typically with surgery, you want to have the tumor out as soon as possible. And even though we take pride on the fact that we move very quickly from diagnosis to surgery, these are not the times to do that. And what we do, though, is we assure that we create a whole screening system, and that involves discussing with other physicians. We have weekly tumor boards, but there are tumor boards that are focused on certain areas of disease. Then on those tumor boards, now it is incorporated, okay, what do we do on these COVID times? And what would we do with a relative of ours? Do we operate or do we postpone? Then it's interesting because we have found out that in many cases, we could send patients to neoadjuvant therapy. And we already were doing that before. Now we do it more, as long as the group and the science feels that that's not going to be detrimental to the patient. Then which patients are we still operating? Because we are still operating. Those patients in which a diagnosis is not clear, and therefore, if you do not have a clear diagnosis and we are suspecting that you have cancer, that that tumor is cancerous, but by biopsies, we couldn't really prove that, then we cannot send you to chemotherapy because we don't have a diagnosis. What do we do then? Then we have to take you to surgery and give you the treatment as we would give you normally because we cannot do chemotherapy. The other patients that we are doing surgery are those patients that have been on chemotherapy and are not tolerating it well, or those patients that have reached maximum doses or are what we consider maximum doses of chemotherapy, and exceeding those probably would not be beneficial. Then we take you to surgery. What do we do when we take you to surgery? Similar precautions. We test every single patient, not because we doubt you, but because we need to make sure that the person that it is going to be in the operating room, he has tested negative. Then we are very fortunate that we have that capability here at Miami Cancer Institute and at our Baptist Health main hospital, where we do the surgeries, that we can test any patient that's going to surgery. Now, that I just said in a very simple phrase, it has taken a significant effort by the institution. That does not come easy, because when we hear our leaders saying that there is shortage of testing, and we are able to somehow be able to obtain whatever equipment is necessary for us to provide that care, as a surgeon, makes me feel good, because that's the way how I would like to treat my patients. Then that is a significant sense of security. Now, in terms of visits, the two prior speakers have already talked about telehealth. It's interesting. I am very fortunate that I receive a lot of patients from out of town and even from out of the country. And today I ask myself, how bad of a guy I was. I used to have them take a plane and come to see me for a postoperative check, or even have to see me preoperatively several times before we decide to do surgery. We learned that with telehealth now, doing what we're doing today, but doing it through another platform, we can actually see patients in the comfort of their homes. And then they don't have to come all the way here unless we need to do a physical examination, and that are several patients. Or if we are pre-op, I like to see my patients at least once. Not because I'm good looking and I want them to see me, but because I think that despite of these great platforms, we still need to know each other, to have a bond that allows us, because I'm the one that is going to be putting a knife in your body when you're asleep. Therefore, I want you to know me. I want you to feel comfortable with me. Then, despite of all of this, and despite that we have decreased the number of visits in person, we do want to meet our patients in person prior to surgery. It's going to be interesting to see what's going to happen after this crisis goes away. Are you going to like these platforms? Are you not going to want to come all the way here every single time? And only time will say, but it is important that you give us feedback on that. And talking about feedback, before giving it to my next speaker, I want to tell you that please give us feedback on the chat. Try to give us constructive feedback, even if it is not good. Yeah, we want to learn. We are trying this for you, and we want to do more of this if you find it useful. And you can even suggest what subjects would you like this type of what we call webinars or Zoom meetings would like to be, meaning Would you prefer to talk about medical parts? I mean, this originated because we needed to do one of these on pancreatic cancer, and I thought probably people are not going to want to hear about pancreatic cancer now. Probably they're going to want to hear about COVID, and the whole group, we thought about doing this webinar. Then, like that, we need to hear your feedback and tell us what would you like us to do on future webinars like this. Then that is a brief summary of what is going on in surgery, and any other questions that you have, will be responding them at the end on the questions and answer session. Our next speaker is Dr. Milton De Birria. He is one of the heroes. We are still taking care of patients, and we are putting our lives at risk. But Dr. Gaviria is on the front lines. He is in the battlefield. It is a privilege for me to try to introduce you a person that is treating COVID patients all the time. And it has guided us through this whole crisis, along with a fantastic group of intensive care, emergency medicine, and infectious disease physicians. Dr. Gaviria is going to talk about antibiotic and antimicrobial stewardship. He is the director of Antibiotic Stewardship program at Miami Cancer Institute. Dr. Gaviria?
Thank you, Dr. Asbun. It's a pleasure. Thank you for inviting me. And it's a pleasure to share this panel with all the experts from NCI. I'll be sharing these few minutes with our pharmacy expert, Tim Gauthier, who will touch on some of the therapeutic aspects. There are many fascinating areas about the treatment and the management of COVID-19. I am going to focus these a few minutes on basically transmissibility. As you heard before from all our panelists, MCI has taken significant steps to prevent transmission of this disease to healthcare workers and to patients. So why is that? Something very particular about this virus, the SARS-CoV-2 virus, the agent that causes the COVID-19, is the transmissibility. There have been several studies at this point that have shed some light into why this virus is so contagious. And there are, of course, more studies coming up. At this point, we know from at least 3 different studies in the Diamond Princess cruise ship, in healthcare workers in Seattle, and also women who came to deliver in New York. We know that approximately 15% of people can be totally asymptomatic. Something interesting is that these people who are asymptomatic, they have as many viruses in their nasopharynx and oropharynx as the people who are symptomatic. Therefore, they can transmit the virus to other people who are exposed to them. We know that in general, one infected person could transmit to 2 or 3 other people this infection. And we know that the transmissibility starts approximately 2 days before the person develops symptoms. So either people who are asymptomatic or pre-symptomatic can start shedding the virus and transmit the virus to other people. For that reason, it is so important that people use a mask, because even if you feel good, you could have the virus and you could give it to other people. The mask is useful to prevent transmission and also acquisition of the virus. But the main role of the mask is actually to prevent from the person using the mask to transmit the virus to other people. So we all are in this together, and we have to be very responsible and wear a mask so that we don't transmit the virus to our relatives and to other patients or to colleagues. That's one of the important aspects of this disease. There are many other fascinating aspects, and I'll be more than glad to answer questions in the question and answer session. I am going to pass now to our pharmacy experts, Tim Gauthier, to briefly talk about the pharmacy and therapeutic aspects of this disease. Thank you, Dr. Asbun.
Thank you, Dr. Gaviria.
So thank you for having me on this panel. It's really quite a privilege to be associated with these very talented physicians and the things that are happening at MCI. So my role is related to antimicrobial stewardship, and that refers to the safe and effective use of antibiotics. And we work as an interdisciplinary team with physicians and nursing and other experts in the healthcare field to see how can we be safer about the way we use antibiotics, getting the right dose, the right drug, the right duration for that right patient with that disease. And so we're very interested in therapeutics related to the treatment of COVID-19 disease. And we've been working with our colleagues as well as looking at the literature. Um, one of the themes in antimicrobial stewardship in general which is a major point we always try to get across to patients, is that, we really shouldn't take medications, prescription medications, without the supervision oversight from a physician, from a licensed healthcare practitioner. And that message rings true a lot here with the COVID-19 disease and some of the therapeutics that are being discussed. Drugs like chloroquine and hydroxychloroquine, which you may have heard about in the press, those are not FDA approved for COVID-19. And they certainly bring a number of toxicity potentials, including heart problems that can arise. And so to take these medications on our own, to take any antibiotic or antimicrobial on our own, will pose us risks, but will it bring us benefit? And that answer to that question is really something that needs to be judged by a physician who has the information to make that risk versus benefit consideration. And so we're trying to provide our clinicians with the information as it comes out. And as you can understand, and as you've seen, I'm sure there's lots of information, there's lots of potential therapeutics, and we're working together as a team to make sure when we do use our therapeutics, that clinician is making that judgment based upon their expertise, and that we're doing what we're doing in the most safe and effective way for our patients. And so that was the major take home: is let the physician make the call on whether or not you need a therapeutic management for COVID-19 infection or also an antibiotic in general. Sending it back to you.
Thank you very much. Thanks for that lecture. During this whole crisis, there's a lot of psychological stress, not only for us, but for you. If you have cancer, there's no question that on top of your fight that you have had with the cancer, now you need to be dealing with this little virus that's going around. We are fortunate today to have Beatriz Currier, who will be talking to us about the psychological aspects of the COVID-19 crisis, and is going to give us some guidance. Dr. Currier is the medical director of the Cancer Patient Support Center at MCI, and is a chief of Psychiatric Oncology. We are fortunate to have her today, and we're fortunate to have a person like her treating our patients. Dr. Currier, please, if you can unmute your phone. That's it.
Thank you, Dr. Asbun. Clearly, this has been an unparalleled and very challenging time for all of us. And every single person is experiencing some degree of stress. And what we know is that with chronic stress, there are physiological changes in the body, which will produce both a host of psychological symptoms as well as physical symptoms. So some of the classic symptoms of stress, and I think many of you will identify with these, include anxiety, fear, sadness, depression, and specifically with this COVID-19 pandemic, a real sense of loss of control in that, it's really not clear to us what the end date may be for this pandemic. So in addition to those psychological symptoms, which are part of the chronic stress response in the body, we also have physical symptoms, which include insomnia, fatigue, changes in appetite, diminished concentration. And I suspect as I'm mentioning these that it may resonate with you or your loved ones that you've experienced a lot of that during this time. So what I wanted to do is just briefly touch on 5 strategies that you can all practice on a daily basis to try to mitigate some of these negative physiological effects of stress in your life. And all of these have been evidence-based strategies that have been shown to actually dampen some some of the inflammation and physiological changes that we see in the body during the stress response. So first, it's maintaining good sleep hygiene practices. Sleep is ground zero for mental health. And most of the population requires a minimum of 7 hours of sleep per night. So that should be your target goal. And some of the routine sleep hygiene rules include, going to bed at the same time and getting up at the same time every morning to have some consistency. You want to avoid reading in bed or watching TV in bed, and certainly try to minimize any blue light exposure after 7 p.m., which means looking at your iPhone, your iPads, your computer screens. Now, if that's not practical because of your lifestyle, then I would at least recommend that you use amber lenses, which completely 100% block blue light, which has a tremendous impact on your melatonin levels. So good sleep hygiene is critical during this time. And once again, the target is 7 hours a night. And please try to avoid alcohol. Unfortunately, in the COVID-19 pandemic, there have been multiple surveys done now where they've shown it's a 30% increased consumption of alcohol that's being purchased across different grocery stores. And most people will use alcohol at night to try to get them to sleep. And although it doesn't disrupt the initiation of sleep, it truly disrupts stage 3, 4 of sleep, which are your deep sleep stages. So you really want to minimize that. The second strategy is you need to incorporate daily regular physical activity. And you're shooting for a goal of 20 to 25 minutes per day, or a weekly goal of 150 minutes per day. And we want moderate activity. So brisk walking would fit that description. And by brisk walking, we don't mean strolling or walking the dog. We mean brisk walking in that you feel a little bit winded. And if you can incorporate 20 to 25 minutes a day, it will have a profound impact on anxiety, insomnia, and sadness, and energy. So please consider that. And what we've done at MCI is we have now transitioned all of our exercise programs for our cancer patients onto Zoom. And we have a list that goes out every week through our email blast to our patients, indicating how you can log into those Zoom exercise meetings. And they're held every day. So I really encourage you to do so. The third activity that I'm recommending, a self-care strategy, is to stay socially connected through technology, even though we have to stay socially distant. That social capital is really important in mitigating this stress-related syndrome that we're seeing in many of our patients. And that social isolation is very detrimental. So use the technology to stay socially connected. We at MCI have also now converted our support groups onto Zoom. So for all of our cancer patients who are seeking that, that's now available to you. And we also have the support groups for our caregivers and their loved ones who also need support during this time. The fourth strategy we're talking about also is now a way to quiet your mind and dampen and to help you relax. And we're emphasizing the use of mindfulness meditation for that. Probably the biggest area of research in stress management has been in mindfulness training. And the research outcomes are quite remarkable in terms of showing that it actually changes genetic transcription to decrease inflammation in the body. But that's a practice you have to really work at and perfect, and it takes some time. So we're strongly recommending using various apps to help teach and train you, with the goal being that your daily dose should be about 10 minutes twice a day of mindfulness meditation practices. And I will provide for you all through this webinar list of different apps that you can use. And here you'll see on your screens various apps, and we'll make sure that we get this to you on email And then lastly, the fifth strategy is healthy diet. Try to avoid the binge eating of comfort food, which is classic for the stress response. And of course, as I had stated, avoid substance use as much as possible. And I would also recommend on the side to try to minimize your exposure to all the COVID news. It should be limited exposure, perhaps 10 or 15 minutes in the morning, 10 or 15 minutes at night, just to be caught up on what's happening and what's being recommended in your community. And lastly, we'll also be sending you a document that has 4 exceptional websites to help you with mental health tips and recommendations, not just for you, but for your families and your children, because this is impacting our kids also. And these websites are truly outstanding, the best I've seen at all. And the tips for the families and the kids are age appropriate and very pragmatic and helpful. So I hope you can use these resources to help you better cope during this time. And these are ways to kind of control that stress response and hopefully get you through this and promote your mental health and resiliency. Thank you.
Thank you very much, Dr. Currier. For the panelists, please now you unmute all your microphones, as long as you're not playing hard metallic rock and roll, and because we're going to be directing some questions. And then thank you to the attendees for putting the questions up on the chat bar. Then, Dr. Gaviria, there is a question: what specific organs are being affected by COVID-19?
Yeah, thank you for the question. Yeah, certainly the initial manifestation, the initial infection happens in the upper respiratory tract, nasopharynx and oropharynx. We see some symptoms the first week. Something interesting about this disease is that by the second week is when patients really get sick. We see by PCR studies that the virus certainly moves to the lower respiratory tract and then causes pneumonia. From that point on, either people can get better by the end of the second week, or unfortunately, in bad cases, patients can get very, very sick. Everything starts as low oxygen and shortness of breath with respiratory failure. Unfortunately, from that point on, the virus can affect other organs, especially the heart, leading to heart failure and manifestations of heart failure, can affect the kidneys. I have seen many patients with renal insufficiency requiring dialysis. Some patients have developed liver disease, especially hepatitis. And another phenomenon that seems to be common is thrombosis, the development of thrombi in different organs. So the disease seems to begin in the lungs, unfortunately spreads to other organs, and ultimately can affect even the brain and the skin. We have seen encephalopathy, changing behavior and mentation, and also a different type of skin manifestations.
Thank you. Now, obviously, that is the patients that we see, which are a minority of patients, despite that the diseases can be deadly. I just want to remind everybody, it's a small percentage of patients, the ones that get to those stages. Nevertheless, it is big enough to overwhelm some the healthcare system, and that's why we still encourage to continue the isolation measures, because that appears to be the main intervention that has been able to prevent the disease. Another question is, what are we being asked to give blood? I'll take that question because it says, how does the blood donation help those with COVID-19? It is my understanding, and I'm going to let the other panelists chip in if I'm wrong, that really is not the specific to the COVID-19 patients, but it is actually just a very common fact that it's that people are not donating blood anymore. Then as we need blood in regular basis, then the blood banks are depleted. And now if we're doing surgeries for any patient or any patient that presents with hemorrhage, the blood that we normally have available is not there. then that's why we are asking you to donate blood. And yes, some of the patients with COVID may need blood, but that's not directly related to the disease itself. It's more a matter of people not going to the blood bank as they normally do to donate blood.
Agree.
Then question for Dr. Venkatappa. As you gave some statistics, do we know about somebody that has finished chemo but still is taking medication as anastrozole? How dangerous it is? Are those patients also at an increased risk as the ones that have cancer?
So, no, there is no increased risk for COVID-19 in patients who completed chemotherapy and who are on maintenance hormonal therapy, such as anastrozole. Anastrozole is an anti-hormonal therapy. I'm sure your doctor has been checking your labs at least once or twice a year, even on the anastrozole. And as long as your doctor did not say that you had a low white blood cell count, you should be fine, and there's no reason to stop the anastrozole. The only time to stop the anastrozole, if you choose to, is if you unfortunately were to develop COVID-19 infection, then you can stop it for that 1 week when you're on all the other medications, and then you can restart it once you get better.
Thank you very much. I appreciate it. The whole panel, what if I live with a person that is infected with COVID-19?
Can you repeat that question, please?
What if, I assume the question is in the context of, now I am an MCI patient, the person is an MCI patient that has cancer, and now somebody in the house has gotten infected with the COVID-19. What do they do?
I would say that they should call their oncologist, whoever their primary oncologist, and they will be directed appropriately to come and get testing here if they're on active treatment. If they're not on active treatment, if they're just on maintenance and see us once a year, they will be directed to their primary care physician or one of the local testing centers. But if you've been exposed to somebody who tested positive and they're your family member or close friend, then it is prudent for you also be tested so that you don't become an asymptomatic carrier and spread it to others.
Thank you. Somebody asks, why is that sometimes they ask us to take the mask and put a thermometer in the mouth, I assume, rather than doing the one on the skin? Well, the one on the skin is not as accurate. And remember when I was joking, but it was not a joke, that I was driving with the windows open and it was a hot day and I arrived to the hospital at 8 o'clock in the morning. My surface temperature was above what it normally needs to be for surface temperature. Then I had to go to secondary screening and get the mouth temperature. Then the mouth temperature is more accurate. Then the surface temperature may serve sometimes just for screening, but it's not as accurate. Another question, will MCI be offering antibody testing?
If I may, the answer is we're working towards offering antibody testing to everyone. I think all major centers all over the world are trying to get to where we can do antibody testing on large groups of people. Our effort here has been led by Dr. Ed Gould, the chief of our pathology department, who's done a fantastic job with getting the FDA to approve the testing for COVID, and he's also working on antibody testing. I'll let Dr. Gaviria add to that.
Sure. Yeah, thank you, Dr. Venkatappa. Yes, as of yesterday, actually, some of the commercial labs, Quest and I believe LabCorp, have begun also providing testing for antibody testing. So I am actually getting tested this afternoon. But yeah, so some of the commercial labs just as of yesterday started offering the antibody test. So by our order from your oncologist or your primary care physician, you may be able to get the test in a commercial lab.
Thank you.
Sure.
I'm not sure who asked this question, but whoever asked this question, I love you. The question is, how is MCI supporting physicians and clinical staff to deal with their stress and anxiety? Dr. Currier, that means that you care for us. Thank you.
Right. Yes, we're trying to provide similar support as what I've mentioned to you, the participants in this webinar. First and foremost, we're teaching and we're offering free training in meditation mindfulness classes for all the staff, and that has been extremely well received. In fact, we're overbooked with that. We also have support groups online, and all of this is virtual for our staff. And we also provide counseling sessions for any of our staff throughout this COVID crisis. So we're very mindful of it. We're very vigilant in trying to maintain mental health because we know that our staff have to do well and have to be safe and protected in order to take care of the patients.
Thank you very much, Dr. Currier. Dr. Chuong, they are asking us, how are new patients needing oncology evaluations receiving care?
I'm sorry, I didn't understand the question.
How are patients that need, new patients that need an oncologic evaluation, meaning a new patient that has a cancer, is diagnosed, how is it evaluated here at MCI? Are we decreasing? I know the answer, but I want you to answer it. Are we decreasing the consultations with new patients? Are we delaying the consultations for new patients?
I understand the question now. So, so the answer to that is absolutely not. So initial consultations can still be facilitated in many ways. They're a lot easier, as you mentioned, Dr. Asbun, by telemedicine. So, through web chats and whatnot, like this webinar, initial consultations are still happening. The physical exam component, of course, is not possible through a web chat. And when appropriate, if a physical exam is critical to a diagnosis or to proceeding with management for staging, et cetera, then there might be a rationale for a patient to come physically into the building. But whenever possible, if we can do it by telemedicine, then we certainly would do so. So the short answer is no, we are not limiting consultations, but really triaging whether that can be done in person or by telemedicine.
Thank you, appreciate it. Dr. Venkatappa, how are you dealing with the follow-up PET scans and CT scans that normally need to be done on patients? Then you tell them from the medical perspective, and I'll say it from the surgical perspective.
Sure. So if you're actively, there are three scenarios. You're a brand new patient, newly diagnosed, you get priority. You will get scans just like you would have got scans whether there was COVID-19 or not, because we need to know what stage of the disease we are in, because that's critical to our treatment planning. So there's no change for new patients. For patients who are under active treatment, and we need to make a decision whether treatment needs to continue or not, they also get priority, and we will get scans. If we feel there are other ways to assess that the patient is responding, say in breast cancer, if I examine the patient tells me that the tumor is shrinking, then I may postpone the scan by another few weeks and continue the same treatment. But if I have clinical suspicion that the patient is getting worse, then yes, absolutely we can get scans. There is no shortage of scanning equipment. There's no shortage of personnel. You will get priority. For those who've had cancer in the past, those who are on maintenance scans every 3 months to 6 months, we will sit down with the patient and we will explain to them that we feel that it would be okay in some situations where, once again, where we have clinical evidence that the patient is doing well through an exam, through history and labs. In that case, we may postpone the scans by a few weeks to a month or two, but not longer than that. So the bottom line is that, no, we are not under-treating anybody. Cancer is really important. We understand it's dangerous, and we will continue to take care of you to the best of our ability.
Thank you. And from the surgical perspective, it's more or less the same. There's plenty of availability of scans. Then if you need a diagnostic scan, absolutely. If it is a regular follow-up scan, we basically ask you, Do you want to come in the middle of a COVID? I mean, you're doing great. There's no evidence that you need to do it exactly at this time. I mean, realistically, despite that we wear a white coat and we want to make you believe that we know everything, many of the things we do is arbitrary, right? I mean, I normally do a 6-month follow-up on a pancreatic cancer patient after I have done the operation and I have taken the cancer out. Why do I choose 6 months? Why not 5 or 7? Then really it's just a number. Then telling the patient, listen, it's fine if you are on the 5th month and you're doing well, rather than doing it next month, we can do it in 2 months, let's do it in the 7th month, then there is not an issue with that. But we let you decide more than anything. Dr. Venkatappa, there's a question of one of the participants that states, I understand that some of the regimes have been adjusted because of the COVID-19, as you have mentioned. When are these regimes going to be assessed to go back to what is the standard protocol back into normality?
So for most regimes, we have a certain timeline. It'll be 4 cycles or 6 cycles, and then we usually reassess with scans. That would roughly be the same time when we get the next set of scans that we will make a decision whether we should stick to the same regime, whether it's safe to go back to the standard of care, or whether we should switch to something completely different. Unfortunately, none of us know exactly when this pandemic is going to get over. We are planning, at least in the medical oncology world, that this is, we started all the restrictions sometime in the middle of March here in Miami. And so we are hoping that by the middle of June, that's 3 months, we will be able to lift some of these restrictions. I hope it's sooner than that. So we're planning for all of these regime changes, these altered regimens to be from March to June, and we'll reassess on a patient-by-patient basis after that.
Thank you. We are now on time. It's 3:32. I want to thank the speakers for having allocated this time on your days to be able to talk to all the patients and make yourself available for questions and answers. I want to thank the participants. There's one more question people are talking about, are asking about resources, and the website is events.baptisthealth.net. Then this is more for meditation, exercise. Again, events.baptisthealth.net. And that there is a variety of events that may be of aid, and you can choose besides the ones that Dr. Currier had mentioned, particularly those for meditation, the list of apps, etc. Just as before I close, I want to make sure that we all remember that this one day will pass. And even though it seems that, thank you, they're sharing the screen with all the events. Thank you very much. Even though right now we are all frustrated and we all have some fear, us, we all have fear, but we need to honor that feeling. The fact that we have fear doesn't mean that we don't have courage. Sometimes we make that mistake, but courage and fear are not exclusive, and we need to honor both. It's okay for me to feel concerned if I'm going to be doing rounds. It is okay for Dr. Gaviria, that is treating patients that have COVID, to feel fear. But the fact that we come and work shows that we have courage. The same thing for you, or maybe even worse for you. You have more courage. You have a cancer now, and you have to deal with all of this COVID mess. And now you're afraid with the statistics that we just gave you. It's more common in cancer patients. What's going to happen with the treatment for your cancer? Well, it's totally normal for you to be fearful and understand that. You need to honor that feeling. But you're still continuing. You just logged in and gave 1 hour of your day to this seminar. That means that you have courage. You have curiosity. You want to learn. Then let's not all forget that throughout all of this, the human spirit will prevail. And one day, again, this will be over. Thank you very much to everybody, and please be safe.
Thank you. You too.
Thank you.
Thank you.
Thank you.